السلام عليكم ورحمة الله وبركاته. أنا الدكتور صباح عبد الرسول حمودي، حاصل على شهادة البورت في جراحة الوجه والفكين وتدريسي في كلية طب الاسنان. محاضرتنا اليوم موجهة لطلبة المرحلة الخامسة في مادة جراحة الفم. عنوان المحاضرة is Cleft Lip and Palate. Cleft Lip and Palate. The cleft is a congenital abnormal space or gap in the upper lip, alveolus, and or the palate. The general dentist will become involved in management of the cleft lip and palate special dental needs because they may have partial endodontia and supernumerary teeth. Malocclusion is usually present in patients with a cleft lip. An orthodontic therapy with or without corrective jaw surgery, orthodontic surgery, is frequently indicated. The management of the cleft lip and palate require team approach. The team approach that is involved in the management of the cleft lip and palate consists of plastic and oral surgeon, orthodontist, prosthodontist, pediatric dentist, ophthalmologist, psychiatrist, speech therapist, nursing support, social workers, ENT surgeon, and or with genetic scientists. Incidence and prevalence of the cleft lip and palate. The incidence of the cleft lip and palate is about 1 per 700 births. The black people have the least incidence of 0.4 per 1,000, while the Asian having the highest incidence. Cleft lip and palate together occurs about twice as often in boys as in girls, whereas isolated cleft of the palate without the cleft lip occurs slightly more often in girls. 75% of people with the cleft lip and palate are unilateral deformity, and 25% are bilateral. The left side is involved more frequently than the right side, so the cleft lip is more frequently occur on the left side than the right side. This figure showing the variations in the manifestation of the cleft lip and or palate. The cleft lip may involve the upper lip and may extend to the nostril or on the primary palate. Clefts may be unilateral or bilateral. The cleft of the palate may be isolated or may be involve the primary and the secondary palate unilateral or bilateral. This figure showing the variation in the cleft lip and palate. As in this figure showing the notch of the upper lip. This is type of the cleft lip. Cleft of the soft palate may also show wide variations from a bifid uvula to a wide inoperable cleft. The bifid uvula is the most minor form of the cleft palate, in which only the uvula is clefted, as we seen in this figure. Another variations of the cleft of the soft palate is the submucosal cleft. In the submucosal cleft, we cannot see complete cleft of the soft palate, but the clefting occurs in the underlying muscles. To diagnose such a defect, the dentist Inspect the soft palate while the patient say, ah. Palpate the posterior aspects of the hard palate to detect the absence of the posterior nasal spines and the presence of the hypernasal speech, as we see in this figure. Embryology of the cleft lip and palate. Cleft lip occurs due to the failure of merging between the medial nasal process and the maxillary process at the 5th week of gestation on one or both sides. This results in cleft lip. The palate begins to develop in the 6th week. The palate develops from the primary palate from the medial nasal process, while the secondary palate develops from the maxillary process. Fusions of the palatal shelves begins at the 8th week, which continue till the 12th and 17th week of gestations. Cleft palate occurs during this period between the 8th week and 17th week of gestation. The causative factors of the cleft lip and palate. It is important to distinguish between isolated clefts and clefts associated with other birth disorders or syndromes. There is usually interactions between the hereditary or genetic factors and environmental factors. Environmental factors such as nutritional deficiency, radiations, several drugs may cause the cleft lip and palate such as retinoid, hypoxia, viruses, and vitamin excess or deficiency. What are the problems associated with the cleft afflicted individuals? The patients with the cleft usually complain of number 1, dental problems, which consist of either of endodontia, congenital absence of teeth, or supernumerary teeth, presence of extra teeth, as seen in these figures. Malocclusion. Patients with the cleft lip and palate complain of the full of malocclusion. And this malocclusion usually results from because the maxilla may be deficient in all 3 planes of space, with protrusion, constriction, and vertical underdevelopment. Cleft patients are usually presented to us with class 3 malocclusion due to the retardations of the maxillary growth, while the mandibular growth is normal. So the orthodontic treatment may be necessary. Space maintenance and control is instituted during the childhood. Appliances to maintain or increase the width of the dental arch are frequently used. This treatment is usually begun with the eruption of the first maxillary permanent molar at age 6. 3. Nasal deformity. The alar cartilage on the cleft side is usually flared, while the columella of the nose is pulled toward the non-cleft side. Surgical correction of nasal deformities should usually be deferred till puberty. 4. Feeding problems. Patients with the cleft have extreme difficulty in producing the necessary negative pressure in their mouth to allow sucking either breast or bottle milk. To overcome through the use this problem, through the use of specially designed pulse eyedroppers or large syringe with rubber extension tubes. Ear problems. Patients with cleft usually presented to us with recurrent infections of the middle ear. And these infections occur due to the imbalance of the pressure between the pharynx and the middle ear through the extension tube. It is usually treated by the ENT surgeon by doing the procedure called the margotomy. 6. Speech difficulties. 4 speech problems are usually created by cleft lip and palate deformity, and these include retardation of the consonant sounds. Hypernasality is usual in the patients with the cleft of the soft palate and may remain after the surgical corrections. Articulation is a problem and hearing problem. 7. Associated anomalies. The cleft patient usually have other associated anomalies such as the clubfoot, neurological disturbance, heart disease, and others. Treatment of the cleft lip and palate. The aim of the treatment of the cleft lip and palate is to correct the cleft and associated problem surgically and thus hide the anomaly so that the patient can lead normal lives. The aim of the lip and palate repair is to restore the aesthetic and function. In addition, is the enable and create the reduce the infection of the middle ear. The patient too can be speech normally, reduce the infection of the middle ear, and can be feed and swallow normally. Repair of the cleft lip and palate is a stage procedure, so that the cleft lip repair usually according to the rule of 10, usually after 10 weeks when the patient weighs 10 pounds and the patient hemoglobin is 10 milligram per deciliter. This is called the rule of 10, which is usually used in case of the management of the cleft lip. While the cleft palate repair should be performed between 9 and 18 months, because after 18 months the repair of the palate, because after this period the development of the speech will be occurred. And if the repair of the palate is late after 18 months, the difficulties and the problems of speech and phonations persist. And the cleft repair palate should be repaired, not repaired before 9 months, because the growth, because it causes a severe restriction growth of the maxilla. Pharyngeal flap or pharyngoplasty usually is performed between 3 and 5 years or later, based on speech development. Corrections of the alveolar cleft with bone graft usually done between 6 and 9 years, based on dental development. After that, half to 2/3 of the root of the canine is formed. Orthodontic surgery, which is used for corrections of the jaw relationships, is usually done after puberty. between 14 and 16 years in girls and 16 and 18 years in boys. Cleft rhinoplasty corrections of the nasal anomalies is usually done after age 5, but preferably at skeletal maturity after orthodontic surgery when possible. Cleft lip revisions, when needed, can be done anytime one's initial remodeling and skull maturation is complete, but best performed after age 5 years. This is the optimal time for repair of the patient with cleft lip and palate and other deformities. Calligraphy. Calligraphy is a surgical procedure for corrections of the cleft lip deformity. The objective of the calligraphy are twofold: functional and aesthetic restoration. The calligraphy should restore the functional arrangements of the orbicularis oris muscles, as seen in this figure, and create of the oral sphincter. The normal anatomical structure of the upper lip should be restored by the calligraphy, such as the cubic bow, philtrum, white rule, alar rim, and philtral dimple. The most common procedures used for corrections of the cleft lip is the Miller procedure, or called rotation advancement flap. In this procedure, 3 flaps are developed, A, B, and C, for restorations of the orbicularis oris muscle. And also for the creations of the nasal floor. Palatography. Palatography is usually performed in one operation, but occasionally it is performed in 2. In 2 operations, soft palate closure is usually performed first, and the hard palate closure is performed second. The most important and famous procedure for palatography is the bone lunging procedure for the closure of the hard palate. Bone lunging procedure involves the closure of 3 layers: nasal mucosa, muscles, and the oral mucosa. First, it is used lateral relieving incision to reduce the tensions of the suturing that occurs in the midline of the palate. The most common complication after the bone lunging procedure operation is the development of the oronasal fistula and the development of the phonation problems or hypernasality. Alveolar cleft grafts. Correction of the alveolar cleft should be postponed after the age of 6 years old. The alveolar cleft defect is usually not corrected in the original surgical corrections of either the cleft lip or the cleft palate. The alveolar cleft are usually associated with oronasal fistula. The aim of the treatment of the alveolar cleft. or restore the physiological continuity of the dental arch to enable oral and dental health to be maintained. 2. To provide bone for the stability of the dental arch, premaxilla and adjacent teeth, and to allow for eruptions of unerupted permanent teeth, usually canine, or replacement of dental implants, to allow for the orthodontic alignments of the teeth, to provide support for the lip and nose, and to close a persistent oronasal fistula. And lastly, the aim of treatment of the alveolar cleft is to cause minimal impairment of the growth and development of the maxillofacial complex. The optimal time for the grafting of the alveolar cleft is between age 7 and 10 years old, ideally when 1/2 to 2/3 of the unerupted canine root has formed. By this age, the growth of the maxilla is finished. So there is a little risk for the impairment of the maxillary growth. And also by this age, this allows the development of the unerupted canine into the grafted cleft. Management of the alveolar cleft. Firstly, orthodontic expansions of the arch in patients with the cleft should be done after age 6 years old towards the development to correct the maxillomandibular relationships. After the correction of the orthodontic expansion, the role of the surgeon is the soft tissue incisions. The surgery is involved in soft tissue incisions for alveolar cleft. So the flaps of the nasal mucosa, palatal mucosa, and labial mucosa must all be developed and sutured in a tension-free, watertight manner. Bone graft is used, which may be autogenous, cancellous, or allogenic bone. And the mucosa is closed in a 3-layer: nasal mucosa, bone graft, and oral mucosa. This figure showing you the steps of the procedural corrections of the alveolar cleft by using autogenous, cancellous, and cortical bone. Corrections of maxillomandibular disharmonies of the surgery. The individual with a cleft deformity will usually exhibit maxillary protrusion and transverse maxillary constriction resulting from the cicatricial contraction and fibrosis of the previous surgeries. In these cases, orthodontic surgery procedures are indicated to correct the underlying skeletal malrelationships. Total maxillary osteotomies are necessary to advance and sometimes within the maxilla. Another important procedure which is commonly used in cleft patients is a pharyngeal flap. Patients with the cleft palate usually complain of the velopharyngeal insufficiency, and this can be corrected by using pharyngeal flap, which is in which the rectangular flap from the posterior pharyngeal wall is taken to narrow the nasopharyngeal inlet. Role of the dentist in management of the cleft patients. The dentist must be aware of the overall treatments plan formulated by the cleft team for the patient management. Avoid performance of any irreversible or costly procedures on teeth that may be charted for extraction in the future. Example, bridge for the missing lateral incisors, extractions of the supernumerary teeth. Oral hygienic measures may be difficult the cleft patient, especially at the cleft area. And these individuals may need more frequent prophylaxis and special oral hygienic instruction with careful reinforcement. Prosthetic speech aid appliances may be performed to help the patient with the cleft patient during phonation and eating. In this figure, we see prosthetic speech aid appliance, which is constructed of the acrylic. Thank you for your listening.